Kia ora koutou, welcome again. I'm Pauline from Mobile Health, and it's my pleasure today to introduce our speaker, Nicola Corna. Nicola, who was born and raised in New Zealand but moved to South Africa in her teens and did her nursing training there, has included midwifery in her training. She came back to New Zealand in the 1990s and is experienced now in burns, plastics and specialty surgery. And she got all that experience before she moved to Auckland. And she's now based at Middlemore Hospital, where she has developed her interest in respiratory nursing. She has a master's degree and is a nurse practitioner. Nicola works across primary, community and secondary health as part of the respiratory team at Counties Manukau. Her areas of expertise include non-invasive ventilation, respiratory failure, interstitial lung disease and airways disease, COPD, bronchiectasis and asthma, so she's very well qualified. She's part of the team developing New Zealand's first COPD guidelines, which are currently out for consultation and will be launched later this year. So welcome, Nicola. Thank you.
Thanks, Pauline. So today we're going to talk about COPD management. That's our outline, which, we'll whiz through. We'll see how far we get through all of that. So why are we talking about COPD today? Well, this slide is from the Asthma Foundation from a couple of years ago, and I think it's quite explanatory in that it talks about the burden of respiratory disease, namely asthma and COPD across New Zealand. And what we take away from that slide is that airways disease is very, very common, and it costs our country a considerable amount of money. So, crack on our definition of COPD. I've put a couple of definitions up there. The top one is, one from Gold. I really like the Gold definition there in the middle. And the thing I really particularly like about this particular definition is that it doesn't just talk about COPD as being a smoking-related disease, but that it is also caused by significant exposure to noxious particles of gases. And I think that when we're going into the diagnosis of COPD, or when you're considering whether the patient in front of you has COPD, that you cannot lose sight of the fact that that is included in our broader definition of COPD. As you see as well, previously it was known as chronic bronchitis and emphysema, and that we still, even though they're not actually included in the diagnosis, when I'm talking to patients about COPD, I use those terms because they're terms that people understand, and they're also quite easy to understand if you're looking at them from a pathological perspective. I think one thing that's really also important to note is that COPD is underdiagnosed, and it is a life-threatening lung condition, and that the earlier we pick it up, the earlier we diagnose a person with it, the more effective our treatment is, and prevention of further damage to those airways is done. So just very briefly, a review of our anatomy and physiology. So we start off with our airways start with our nose and our mouth, which is not reflected in this particular slide, and then our airway comes down. We have our trachea, and then at the top of our lungs that branch off into essentially 5 main bronchi. And then of course that we have 3 main bronchi on our right and 2 on the left, because our heart is positioned around here, and that these bronchi then branch off, getting smaller and smaller and thinner, going in all directions. They branch off around about 18 to 25 times, with each time being called a generation. And then at the very, very end of our tiny little terminal bronchioles, we have our little alveolus. So if we put our thumb and our forefinger together, that is about the size of your main bronchus. And if you're looking at the terminal bronchioles and you look at one of these black lines on the screen here, that's probably around about the size of your terminal bronchioles. So you have quite a wide variation in size of airways, but the structure of the airways remains essentially the same the whole way through. So the structure of our airways is really easy, very simple. And when we're talking to patients, I talk about it as having 2 layers. So the inner layer here is our ciliated epithelium, and our outer layer here is our bronchial smooth muscle. And it's really important for patients and clinicians to understand that our smooth muscle works the same in everybody. But the damage in our airways starts here in the inner part of our airway. And when we go on to doing things like talking about medications, I find that this distinction is super important, because often medications that patients reach for first are the ones that work here in our bronchial smooth muscle, and they don't necessarily address the treatment area, which is here. So when we go back into having a look at COPD, that distinction between, as we said, chronic bronchitis, try to find my little pointer, chronic bronchitis up here, and emphysema. So what's happening here? Well, here's our healthy airway, there's our bronchial smooth muscle on the outside, here's our ciliated epithelium, and over time, damage happens caused by exposure to noxious particles or smoking in the inner part of our airway, in the lumen here. And this gets swollen and irritated. And then when something gets swollen and irritated in our body over time, it eventually causes scarring all the way along those airways. And you can see there's excess mucus production, and you can also see that the lumen of the airway has narrowed considerably. So you can imagine that if that bronchial smooth muscle closes down and you've got a narrowed lumen, that person ends up not being able to breathe as effectively as they can. And then when we add in emphysema, which is looking at your alveolar here, nice septum, you can have gas exchange happening through here. And then when that is obliterated, there's a decreased surface area for gas exchange to happen. I particularly like this slide because it has quite a simplistic way of looking at what happens. It's pinpointed smoking, but it can also be, as I said, exposure to noxious gases. And this is where you have this inflammatory response that's triggered by exposure to these, and then they just literally start dissolving these septum. And they're depositing deposits into the airway as well, which is helping to reduce the surface area and reduce the integrity of the tissue, which allows for gas exchange. Oh, just going back to that, just going back to the airways themselves, if we were to dissect your airways open and lay it out flat, one set of lungs would cover half a tennis court in terms of area. And so this is why this process takes so long to happen when we're looking at whether a person has got COPD or not. So when we're having a look at what are we considering about diagnosing COPD, well, first of all, you get your patient coming to you, and frequently they say, I'm getting short of breath when I'm doing things, I might have a bit of a cough, or I might cough up a bit of phlegm now and then. And I mean, those symptoms can apply to lots and lots of things. And for the most part, the patients would have also done a little bit of management of that themselves. They would have said, I'm just getting a little bit older, I'm not as fit as I used to be, or they might be sort of just minimizing those symptoms at that point. And this is one reason why diagnosis of COPD is delayed, because people just sort of put up with it and they think, oh well, I'm getting a bit older, a bit fatter, and they sort of write off these things and they say, I've got too many other things to worry about. My GP is just going to tell me to go home and get fit and lose weight, you know, and not actually go down the path of diagnosing things. So as a clinician, it's really important to take a really good history. We're wanting to know, you know, smoking. We want to know about what have they done as occupation, what pollutants have they been exposed to. And then spirometry is required to establish diagnosis. And in terms of equity and access to care, this is a great big barrier because a lot of places don't have access to spirometry. You might have, and in this current COVID environment, we're being encouraged not to do aerosol generating procedures. So at times, the very thing which we think will be able to tell us whether this person has got COPD or not is actually not available to us. And so again, when we're looking at whether you've got a diagnosis of COPD, what is it about the dyspnea, the shortness of breath? It's progressive, worse with exercise, and it can be persistent. They may or may not have a chronic cough. If people have got wheeze, often people will say, oh, that's asthma, and they'll treat it as asthma. They may or may not have respiratory tract infections. And then, of course, these risk factors are super important. This was really brought home to me at around about 10 or 12 years ago. On one of the World Spirometry Days, we set up a stand at the front of Middlemore Hospital and to do spirometry on people as they walked into the hospital. And at one stage later in the day, a number of our cleaning staff came up and had spirometry. And when we did their spirometry, they all actually had a diagnosis of COPD. None of them had ever smoked. But several of them were immigrants. And when we talked to them about home environments when they grew up with kerosene heating in their homes and kerosene lighting. They grew up in small farms where they had, or villages where there was cooking fire exposure, or sugarcane plantations where they had burn-offs and things like that. And it was these things which were the risk factors towards these ladies having COPD. And I think one thing that we can't miss is also, I'll go back, going back into childhood, was this person, did they have a low birth weight? Did they have childhood chest infections? Because, maybe you're not looking at COPD. Maybe they do have smaller lungs than normal. And so you have to take these factors into account when you're interpreting tests and you're looking at the likelihood of whether this person has COPD or whether there is another differential that can be applied in this circumstance. So going back to the guidelines, I quite liked this particular one when it first came out from Gold, because it moved away from the previous diagnosis, which was all around FEV1 and a ratio. Okay, and I think that this was far more representative of what we actually see in clinical practice, because for the first time they're talking about severity of COPD. They looked at the person's exacerbations and they also looked at their function. So they brought in the MRC, the Modified Medical Research Council test, and an assessment of daily function. And so if the person could be, and I have seen this, a person who's gold in that category, gold 4, I've seen a person who has an FEV1 of 15%, who never has any exacerbations and is working full time. And so he actually sits down here, whereas with previous classifications, he would have been in the very severe COPD. So the thing is, he does actually have very severe COPD, but it's not, it doesn't impact on him on a daily basis. And conversely, you have people who have, they might be sitting up here, say a gold 2, but they have frequent exacerbations. They're very symptomatic. They can't walk very far. They can't do very much at home. And I think it's reassuring to patients as well, because they used to think, oh, but I'm severe, or I'm not so severe, but why am I getting sick all the time? And we were, and with this particular way of assessing things, we can actually say to our patients, it's not all about spirometry. It's about how you function and how you manage things. So I suppose it's about looking at the treatable traits. So this is the Modified Medical Research Dyspnea score. It's a really useful tool. Get a copy of it, laminate it. It's really, it gives you a good assessment of how that person's functioning. And you just put it there and say to them, how breathless are you? And you can then quantify how breathless they are. And what happens is that usually when patients look at this, they might start at, they might say vacillate between MRC level 2 and MRC 3. And you just take the one that's higher for them. Right. And the CAT, sorry, this is very small, the COPD assessment test. This is available online as well as in packs from pharmaceutical reps and things. And what it basically does is it looks at those 8 domains: cough, phlegm, exercise, activities of daily living, how confident are they leaving the home, sleep and energy. And the reason why this is a really useful tool is because it also directs you immediately into the things that need to be addressed first from a patient's perspective. So what are we doing in terms of looking at what other differential airways diseases out there? Taking a careful history is the most important part of that. We want to know what their exposure to noxious particles are. When I do a smoking history, I don't just ask about cigarettes. I ask about marijuana. I ask open-ended questions. What have you ever smoked anything else? And sometimes people get a little offended, but usually I can say to them things like, the most unusual thing I've ever heard of is corn cobs wrapped in tobacco and banana leaves. Or during the war, people used to smoke tea leaves, and they used to smoke cinnamon sticks. Pacific cigarettes, so they're usually known as by Tongan cigarettes or Samoan cigarettes, and the plant actually grows very well here in Auckland. But it's worthwhile remembering that tobacco cigarettes didn't make it to the islands until the 70s, and so if you've got someone who's much older, you specifically ask them, oh, did you smoke Tongan or Samoan cigarettes? That they will often say yes. What smoke exposure have they had? What about cough and phlegm? How often does it happen? Childhood infections or adult infections? There were some working theories going around for some years about things which trigger COPD. You know, people might say, I managed fine until I had a really bad pneumonia, and after that I haven't been able to get back to my normal. And so it's important just to correlate those things back to the person's functioning. What about exacerbations? And I put the response to antibiotics in there because one of the differentials we're looking at is, does this person have COPD? Do they have bronchiectasis? Do they have asthma? Do they have all three? Do they have two of them? You know, most people don't simply have one standalone airways disease. And to that end, you'll see coming up on the guidelines, and there's been a lot of talk about eosinophils. This particular slide, which is an old slide, but it's a fairly good one because it explains inflammatory cell markers on a continuum. So we have on this side, we have eosinophilic inflammation, mostly associated with your asthma, okay? And then you're going this way, and your neutrophilic inflammation is usually associated with bacterial infections. So straight up, you're thinking about bronchiectasis. You also tend to have higher neutrophils when you've got people who are smoking. So that sits around there. This intrinsic asthma they didn't really know about, but there are some phenotypes of asthma which are more neutrophilic than eosinophilic, but that's not the rule. So I've just popped that in there just for you to sort of get a bit of an idea about this continuum. So this is the continuum here. So you can have neutrophilic inflammation, most predominantly in bronchiectasis, but you may have a bit of eosinophilic inflammation in there as well. And you can see they overlap here on the top. So how are we going to treat COPD? So I decided when I was looking at this that we were going to start with this pyramid of values for COPD interventions. And this was developed by the London Respiratory Network. And it looked at the most cost-effective interventions for the sort of your biggest bang for your buck in terms of managing COPD. And it's a really useful thing to think about when you are looking at the management of COPD, because it's almost like a checklist for yourself. Okay, what am I doing to work through what I'm doing with this person? And for those who are in chronic care management, it's like a little pathway. Let's tick off these things and we head on. So at the very bottom is flu vaccination. Then we've got stopping smoking with pharmacotherapy. Then we've got pulmonary rehab. After that, we've got our inhalers. And at the very top, we've got small interventions. This one says telehealth. But the other thing that's up the top there is things like lung volume reduction surgery, transplant, and very high cost interventions, which may only help a very small number of people. Oh, and I suppose endobronchial valve placement would also be up the top there. I haven't mentioned that anywhere else in this talk. So when I was putting this this PowerPoint together, I pulled out a PowerPoint I did exactly 2 years ago. And I thought the flu that changed the world was quite interesting, because at the moment in this COVID environment, this is definitely changing our world. So flu vaccine it's like a no-brainer, but I spend an awful lot of time talking to people about why we should have flu vaccines, and talking to them about the fact that the vaccine is based on that viruses change and they mutate every year, and that the vaccine is based on the previous year's viruses. But what we have noticed as well is that people who sequentially are getting their flu vaccines every year seem to have a whole lot more resistance to whatever the current strain is. And so I just encourage people just to keep up with their flu vaccines. We won't comment about COVID right now. Smoking, stopping smoking, hard yes, impossible no. And this is, you know, they talk about every cigarette causes damage. And I could have popped the old Pito reference from the 60s in here, but what they talked about at that time was a trajectory of people. So the word emphysema, as in the natural decline of natural deterioration in our lung function that happens naturally every year with all of us, that it is exacerbated with cigarette smoking, but that if when you stop cigarette smoking or you stop the exposure to those noxious particles, the trajectory goes back to what it would have been. You can't reclaim the ground that you've lost, but the trajectory remains the same. And this is why every cigarette causes damage, and why stopping at any point on the continuum of where you've got COPD is quite important. Pulmonary rehab. I can't say enough about this. And in actual fact, if we look at all the evidence around managing COPD and what is the most effective management for COPD, pulmonary rehab actually is more effective than medications. It's one of the most effective interventions that we have. And I just want to reassure you, wherever you are in New Zealand, that there is actually some sort of pulmonary rehabilitation network available near you. Just during the last lockdown, there was a local physio here, Sarah Candy, who set up the New Zealand Pulmonary Rehabilitation Network. I've been on those Zoom conferences. There are representatives there from literally every corner of New Zealand, and they are at the moment setting up an arrangement with the Asthma Research Foundation to be able to put some of their resources, including where the members are positioned all over New Zealand, onto that. So that will be coming out, and it will also be being linked to the New Zealand COPD guidelines, which hopefully will be published in the next few months. So we've had permission from all these patients to use their photos and staff members. This is just taken from one of our programs in Otara from a couple of years ago, those of you who recognise Meg Goodman in the middle of the photo there. And so what happens in a better breathing program or a pulmonary rehab program? Educations. Patients talk about managing their expectations. So that's almost like it's osmosed from them seeing other people around them. But they also sort of understand a little bit better on what they could be doing and what may be better to be paced. We spend a lot of time saying to people, okay, slow down a little bit, or let's look at doing this a slightly different way. Nutrition, we talk about that. And within COPD, you're always giving dietary advice. You're always talking about either gaining weight or losing weight. There's very few who are just sitting there right on the normal weight. Look at breathing training. There's a high degree of disordered breathing patterns in patients who've got COPD. We talk about mindfulness and relaxation. We talk to them about using walking aids. And as most of you out there are aware, offer someone a walking frame, and the first thing they say is, I don't want to look old. So they will often turn it down. But often we manage to get them to, just by showing them in the program, that actually they'll manage to go better and further with a little built-in rest place if they are using walking aids. And there's really good evidence for the use of walking aids and helping to help improve people's mobility when they've got COPD. We're having a look at managing and assessing anxiety and depression, which are, as we know, big components of any chronic disease. Smoking cessation support is always there in better breathing. And because it's a non-judgmental space, that is super, super important. We talk about local social supports and different situations and areas that are available. we get to try out some breathlessness aids like fans, and we also are able to address people's concerns about things like opioids and benzos and other medication therapy, which we'll talk a little bit about later on. So this is another of our better breathing programs. This top one is at Piki, and it's in a netball centre. And you can see patients on the exercycles there, they've got oxygen on. So what they require in terms of aids is usually not a problem at different venues. And I popped this in because this was one of my patients. And I think that you can see he's on oxygen. He exercised, he was on oxygen 24/7, and he exercised on oxygen. So we do assessments in better breathing. You start off with things like 6-minute walk tests, which are actually not as arduous as they might sound. And there is always an improvement at the end of the program. And this is the reason why. And if that comment at the end of the program, he's walking, an extra 50 meters, and he felt only slightly out of breath. You can't capture that difference in a lung function, for example, but you can capture it in a Borg score or in that modified medical research council dyspnea score, and in things like a 6-minute walk test. So these are quality of life type measures, as well as the distance one, which is an objective one. And this man, he also reduced the number of exacerbations that he was having. So this is the latest guideline around pharmacological management of COPD. Don't look too carefully, because I'm going to whiz you on to the not yet published one from our new COPD guidelines. And you can see that it's a lot more simplistic, okay? So if we go back, roflumilast isn't even available. Azithromycin is only available limited people. So this is the take-home one from the new COPD guidelines. There's a section attached to this which talks about eosinophilia, and I will address that as well. But I think one of the nice things about this is that it is quite simple, and it says, divides people into COPD without frequent exacerbations, with frequent exacerbations, and with overlap. So this is the Middlemore inhaler devices chart. There's 2 pages, and if anyone wants a copy, just email Pauline and she'll get me to send one on. I think she has one already, and we're quite happy for people to use them. This is also going to be on the Asthma Research Foundation website too. Essentially, we have a look on the bottom half of this page. You'll see all of your llamas on my left, your right, and on the other side the lavas and llamas. I'm not specifically going into medications here, except I do just want to point out that there is essentially no difference in the way that these 2 groups of medications, that the medications within these 2 groups of medications work. So within the llamas, the tiotropium, umeclidium, and glycopyrronium, there's essentially there's minimal differences between the actions of these particular medications. And that statement is the same between these llama lavas as well. So when I'm choosing a medication with a patient, I literally give the devices, the placebo devices, to the patient, get them to play with them, and see which one the patient finds easiest to use. And that informs the decision about what to prescribe for a patient. And that is super important. So when it comes back to what device, it comes back to what the patient is able to use effectively, coordinate, and use efficiently. That is the most important part of that equation. There is a webinar that I did for the Goodfellow unit. If you go into the Goodfellow unit and you just put my name into it, and you'll go down and you'll see a talk with myself and John Colby, and underneath that is devices or an inhaler the webinar. It's about 20 minutes, and it just goes into how to use all of these devices correctly. So that's available. I'm not going to go into that now here. But what is really, really important is that people are able to use the device correctly, and that they use it efficiently. And of course, you know, it's a bit self-explanatory, but it's super important. And this is why we should be checking these things with almost every patient contact. And it's not just around them using it properly, but it's also these three things: compliance, persistence, and correct technique. So asking patients those questions. And I usually say to them, so which medications are you on? And they'll tell me, and I say, okay, how often are you using it? And they'll tell me, and then I say, okay, how many times a week do you forget? Because that's just human nature, to forget to take something. And I think that helps to, it takes away any judgment, but it also helps to get a better picture of what's happening with the patient, and evaluating again whether they're using the correct device or whether they should be on something else. Opioids. This is just a super brief summary of a talk that I did for our journal club on this, and from an article taken from Thorax, and there was several meta-analyses, these three massive ones, and they all use different methodology. And what they did is actually they were analysed in a couple of different ways, and so the outcomes of that informed the Cochrane reviews around opioid use. And the latest one is that regular low-dose morphine is useful in relief of chronic breathlessness. There has to be, from my perspective, that is one of the last things that we use in managing breathlessness. There's a whole lot of non-pharmacological things that need to be put into place before we reach for opioid medications or benzos or things like that. So the main thing is to make sure that your inhaler therapy is there, get them into moving, better breathing program, and then onto breathlessness management. Here we are. And then once all of those things have been taken care of, then the next line is things like going down the opioid trail. So managing breathlessness, again, just a quick shout out for our new guidelines is that we've developed excuse me, a breathlessness plan. We've developed a breathlessness resource to go, which there's a couple of them. One can be printed off as a one-pager summary for the patient. Another one is about 4 pages, and it is an expansion on that summary. And we've also got a COPD action plan, which incorporates a breathlessness plan into it. So you can go through with the patient and talk to them about what is their best resting position, what do they find effective when they getting short of breath, and you can actually practice those things with them. So these fans are fantastic, and again, it's addressed in our breathlessness resource. The thing that's really important about fans is that the blades are soft, so they don't cut someone's nose if they go too close to their nose. We will look at things like, and when you use it, you point the breeze at their top lip if they're using a handheld fan, and they rotate it like that, and they can use it when they're walking or if they're sitting down or whatever. We want to know why they're breathless. So if the breathlessness seems to be out of context with the patient, go down that pathway, get that echo or the D-dimer or whatever else is needed for that particular patient at that particular time to make sure that that person has been thoroughly investigated. And often, this is where our cardiology colleagues come in, because when we look at breathlessness, there's over 180 different conditions which can cause breathlessness. So there's quite a lot to cover under that. One of the reasons why exercise is so important, and exercise can be often seen as a dirty word. I often say movement rather than exercise. And the reason it's so important is because of this particular cycle. person feels breathless, or they've just had an exacerbation and they've been in hospital and they're feeling upset and they feel a little bit unsafe with all of their breathlessness. So they avoid things which make them breathless. So they do less and they become weaker and they get more breathless, and it becomes a vicious cycle. So that's why it needs to be addressed. So if we're looking at whether a person is having an exacerbation, again, this is from the COPD new guidelines, which will be coming out November-ish. We borrowed this from the St John's ambulance guidelines because we felt that this was a tool that people would be able to use with the person sitting in front of them. You know, how's this person? More short of breath than usual, able to speak in sentences. They may or may not have a wheeze. They might be up here, just have a little bit of indrawing. Their oxygen sats may be normalish and normal level of consciousness, and you go, okay, the likelihood is that this is not too bad. And then you see that things can deteriorate to severe and then to life-threatening. But not everyone has all of those features. It has to be interpreted within the clinical context of the patient. And in the COPD guidelines, what follows this little assessment is a pre-hospital plan of step-by-step what to do with a person who's presenting at different levels here. So just putting that in there. And of course, when you've got a potential infective exacerbation of COPD, using biomarkers is actually really useful. Things like, you want to distinguish this from heart failure. So troponins, do BNP, D-dimers, wanting to know chest X-ray, we wanted to know whether there's something else going on. Because all too frequently, patients are diagnosed with infective exacerbation of COPD, and actually it may not be. Or else are being expensively treated for something which it's simply not. Again, when you look, I spend quite a lot of time in the community, or it's got the brakes on it at the moment with the lockdown up here. But when I'm going in to see a person who has been hanging out for me to come and visit, or, and I get there and they're looking pretty unwell, my go-to is the crib 65 actually. And this is about another just assessment of that person, where they're at, and that discussion about whether they need to be admitted or whether they can be managed at home. And again, this comes out of our guidelines. We've just popped it into just a clear format. And I know that in primary care, people frequently use these as well. What about oxygen? Now, just on the side, Pauline, I haven't got any time thing here, so you'll have to keep me on track with my time.
Okay, you've got 20 minutes left.
Okay, cool. Thank you. What about oxygen? So, super important is this statement here. Oxygen treats hypoxia, not breathlessness. We get lots and lots of referrals here from GPs saying person is severely breathless, needs oxygen therapy. Well, actually, they might be breathless because that's the nature of their condition, rather than the fact that they need oxygen. Sometimes the two collide. And the thing about oxygen is that it needs to be really carefully evaluated, and we have quite strict criteria for international criteria which we use for managing the supply of oxygen. Oxygen should always be prescribed. Your exception is if you have an emergency. There's a couple of terminology things which I think can be quite difficult. Portable oxygen versus ambulatory oxygen. Some of the guidelines tend to talk about ambulatory oxygen. Patients think a cylinder to get me from here to there. Palliative oxygen is usually supplied if the person has oxygen saturations below a certain level and a life expectancy which has been limited. We always assess oxygen requirements when the person is stable and when they've been at rest for at least 20 minutes. And the assessment usually takes place in clinic. And so we find that in terms of oxygen, there's a lot of managing families that goes with oxygen. And I think that is one of the natures of dealing with people who have respiratory conditions, because breathlessness or breathing problems are one of those things where relatives and whānau feel incredibly helpless. And so they feel that that if they can put oxygen on that person, then that's something which is useful and helpful and going to be beneficial. And it can often take quite a lot of discussion before people realise that maybe that's not the best thing for that particular person at that time. But oxygen therapy is also, unfortunately, across New Zealand, available in very varying degrees. I know that in some areas there's no portable or ambulatory oxygen available. And I understand that, and that is a travesty actually across our country, that we don't have the same criteria for supply in every district health board across the country. What about lung transplant? So this is something that people often don't even consider. And this is something that patients can feel really guilty about. I've had patients say to me, well, why would you even consider putting me forward for lung transplant when I caused this myself? And my usual answer to them is, well, what happened yesterday stays in yesterday, but we're talking about your future, we're not talking about your past. The other thing about lung transplant is that they're doing more and more lung transplants these days. And my perspective used to be that I would be the one who gatekept for the transplant service. I'd say, oh, no, I don't think they will take your referral, therefore I won't refer. But our departments had lots of discussions with the lung transplant team, and the transplant team said they would rather take the responsibility for gatekeeping for their service. So if you have someone who you think may fill the criteria for lung transplant, by all means, it's not going to hurt the patient or you to send a referral to the team in Auckland and ask them to consider that person for assessment for transplant. Transplant itself is a massive procedure, and there is a lot that goes into the preparation, the timing. The person has to be super committed to things like better breathing programs, so a pulmonary rehab or an exercise type program. They have to be committed to education. There's a lot involved, but don't discount it, because unless you're the one who's working in the service, you shouldn't be making that decision. You should be letting the service make the decision. So what about palliative care with our COPD patients? I think one of the challenges to palliative care with COPD patients is that where is that point that we introduce it? One of the things I haven't put into this slide on is non-invasive ventilation. And some of the considerations around non-invasive ventilation are that before it's put onto a patient, there has to be a plan for getting it off a patient. And I find that in my patient group that often that is quite intrinsically wound up with an advanced care plan, in that a patient may have an exacerbation of COPD and they end up in hospital and they end up having this mask put on their face, and they come out of hospital having survived that episode, and the first thing they say is, I don't ever want that mask on my face again. And that can often be a very natural progression to saying, okay, well then let's talk about an advanced care plan, because let's put the decision making about what happens for you at the end of your life onto you and not onto someone else. You know, if you want things to happen the way you want them to when you come into hospital next time, then this is a really good way to do it. Other people I find that hospice, they have preconceptions about hospice and about palliative care that are from decades ago. And so having really good links with people in the hospice team and in palliative care are super important if you're working in respiratory, because you've then got people who are able to give the right information at the right time. So saying that hospice care now includes things like antibiotics. It includes, whereas it didn't years and years and years ago, that it is a really positive place where people are well supported. Things like in our local hospices, there's nurses available 24/7, so they can answer some of those calls that people, or queries that people may have in the night. And certainly some of my patients have used those services. But it's a tough one to gauge because you don't know when the right time is to bring it up. And so it's worthwhile. This is one of the great things about, say, the Better Breathing program, is that it's brought up in our Better Breathing programs as just simply one of the education topics. And we approach it from the perspective of you've been in control of yourself for most of your life. When do you want to stop being in control of your life? You know, when do you stop want to let? Is there a point at which you want other people to make decisions for you rather than you make those decisions? And that's often a really good trigger point for bringing in the advanced care planning. I didn't put the website on here, but it is www.advancedcareplanning.co.nz. I think it's co or org. Pop it in and it's in there. And they've got really good resources on there. And they've got some videos on there of people and their journey. I'm in one of those videos with the patient who had bronchiectasis. And the other patient in that particular one had lung cancer, and there's another person there who I think he had COPD. So it's really useful, and it's got lots of sort of talking around type resources on there as well. COVID-19, so I went back onto the World Health Organization website in the last couple of days to update my slides, which had been from March. So the bottom line around their updates were dated from July. So aerosol generating procedures, those are nebulizers, spirometry, high flow nasal prongs, sputum induction, non-invasive ventilation, CPAP, all of those types of procedures. They should be following strict infection control procedures. They should preferably be done in a negative pressure environment, and with people wearing appropriate PPE. If you can't do that, then you shouldn't be doing it. One thing that came up quite at the beginning of COVID was queries from patients about whether they should take their prescribed medications, and they absolutely should. Another thing that's come up on the World Health Organization website was they've done a little, one of their little mini studies, I think they call them rapid research, around whether smokers were more affected by COVID or not. And they couldn't conclusively say that, but they did associate worse infection, high mortality, and more critical care use with people who did smoke. So their bottom line is smokers should stop smoking by whatever means they can. So I've got, Pauline, I've got a couple of case studies just here. Do you want me to address those, or do you want to have a look at any questions that might have come up?
Why don't I read you the questions out, and then you can decide which is most important. So we have got a few here. The first one was a comment really about understanding a nephew's condition, which is called pachyonychia congenita, and just saying that what you had explained really helps Tracy to understand his condition and the build-up of plaque. Sounds like quite an unusual condition, that one. It
does. She can email me directly. My email is on the front of this slide.
Okay. And then somebody's asked, what is the significance of hyperinflated lungs seen on CXR? Then there's a question about vaping and smoking and irritant. And that's it, really. So those are the questions so far, but people may still type some more. There
was a really great question about hyperinflated lungs. So there's two things. One could be that when the person did their chest x-ray, they just took a really super deep breath of air, and that could be what they talk about with hyperinflated lungs is that the diaphragm is a bit more flattened, and you can see the ribs sort of going in more straight lines. So as I said, one reason for that can be that someone just took a really deep breath in when they did their chest x-ray, because you've got to take a deep breath in and then you hang your hands over the structure, and that could just have been that. But the other reason for it could have been because of the emphysema and the chronic bronchitis, the scarring that happens along the airways when you've got COPD, your airways are slower to react than normal. So when you're breathing in, when you're breathing out, instead of them sort of coming, I don't know if you can see my hands, sort of with very little space in between them, they end up with a bit of air trapped there. And then when you take your next breath, again, everything's a bit slower to work. So, and you breathe out, and you've got a bit more air trapped in the airway. And if, say, you're moving, and you end up with quite a lot of air literally trapped in the airways. And what happens is that if you've got air trapped in your airways, your lungs are like a balloon that's been blown up quite full. And so instead of sort of being like half full and being able to expand and contract, they're very full, and it causes your diaphragms to go really flat, your ribs to be pushed out to their highest extent, with very, very severe hyperinflated lungs at the very top, just up here of your and your and your collarbone up here. You can sometimes see like a little bit at the top of your lung poking up if it's severely hyperinflated, and so it's literally filled up with air. And that person, if we were doing this as a face-to-face demonstration, I'd usually demonstrate that by saying, take a deep breath in and then breathe through your nose without letting out any of the air in your chest. And that is that sensation that people with COPD are walking around with most of the time. And that's why when we're looking at breathlessness, they get breathless very quickly because of that. And when we're looking at breathing training, we're teaching them different techniques to help get rid of that air in their lungs. Because the problem is not getting the air in, the problem is actually that air that's trapped and getting it out. Hope that's clear. What was the smoking vaping one? We've written a nice smoking and vaping in the new COPD guidelines, by the way.
The question is, what are your views on using vapes to stop smoking? Surely these are still irritants.
Yep, okay, so I actually wrote most of the section on smoking and vaping in the new COPD guidelines. And my bottom line I say to patients is, God didn't make our lungs to process anything but air. But in the non-judgmental help patients manage what they need to do space that I work in, if the person is vaping and they're finding that is helping them stop smoking, then that's fine. But the next endpoint is to get them to not vaping as well. So vaping should be only used as a tool to get people off the cigarettes. But there's a whole lot of factors involved in vaping, which we don't have time to go into here. But it is things like what's in the cartridges that they're vaping, where are they getting them from? You know, how often are they doing it? Are they because the guidelines are saying, or the international guidelines are saying things like you need to be using nicotine in those, and then you need to be weaning that down. And we want people vaping for as short a time as possible. Hope that just gives you a little bit of an idea about what I think about it.
That sounds really good. Well, you've still got time to look at your case study. You've got 7 more minutes if you want to have a go. Okay.
So I popped a couple of case studies on the end here. Just to chat about. Well, I'll chat and you guys can tell me. You can just listen. So our first lady is a 62-year-old Caucasian lady with a BMI 15. She was referred to better breathing after she'd had a hospital admission. She's a recent ex-smoker. She has depression. She has carpal tunnel syndrome on her right hand. Meds include Vespergen, Spiriva, Vania. She uses morphine elixir every so often. And she's had 2 exacerbations in the last 2 years. So I put her spirometry on there. So if we were looking at her spirometry, her FEV1 is 24% it predicted. So that's pretty poor. Her ratio is 30. She's definitely got COPD. So what are the things which we'd be looking at which are influencing her health? So I think the best thing to do with this is to have a look at the top. Well, she's tiny. She's a tiny little dot of a lady. So if she's presenting and she has a BMI 15, you know, is this a recent event? Has she lost a whole lot of weight with being in hospital recently, or is she always tiny? And that factor alone will give us an idea about whether she will be able to manage exercise classes or not. If this was a recent weight loss, I wouldn't be letting her near better breathing until we had managed to put a bit more weight on, because we want her to be in the best possible condition in order to exercise. But if she was one of my patients I was seeing at home, I'd be giving her a little home exercise program, sit to stands, something quite simple, as well as would be wanting a nutritional assessment done on her, and referring her to the dietitian or to a GP who can prescribe supplements, and also having a look in a fridge and seeing what she's eating and why she's eating. And there's a whole lot of social factors that could be going into what's happening with her, and her social circumstances, of course. Is someone around to do meal prep and all of those types of things. So we could actually go to town on this, and then we'd be having a look at her. We'd also be looking at her medications. If you have a look at that, she's only come in twice in the last year. In the last 2 years, you've been wanting to know what her function is normally, because that will give you another part of the equation in terms of doing assessment with her. We'd also be wanting to have a look at her eosinophils to see whether she does have that component of asthma that is happening, in which case she might not be in the right medications. She might need to have that Spiriva and Vanier changed into a single inhaler LABA-LAMA, rather than the LAMA and the ICS. And I'm also super cautious when it comes down to patients using morphine elixir as well, because I'm wanting to know how often are they doing it, why are they doing it, are they using it appropriately. We can have, and she's tiny, we can have quite considerable effects from that morphine elixir, constipation, etc., etc. Yep.
Nicola, I've got somebody asking, what is FEV percentage? Can you explain?
FEV1 is forced expiratory volume after 1 second. It's a spirometry. It's a marker that happens in spirometry. So when you do spirometry, you take a deep breath in, and then you blow into the machine, and the amount you've blown out after 1 second is that FEV1. The FVC is your forced vital capacity, which is the total amount that you've blown out, and the ratio is 0.48 over 1.61, which gives you your FEV1 FVC ratio. Right. This man I saw recently, actually, GP referral. So when we talk about things like smoking pack years, so he's 73-year-old, he's Fijian Indian, he's an ex-smoker. He smoked 10 cigarettes a day for 55 years. So a smoking pack year is 20 cigarettes a day. 20 cigarettes a day for 1 year is 1 pack year. So if you want to translate his smoking history into pack years, you would just halve his 55, which gives us 27.5 years. And when we're looking at diagnosing COPD, generally it's around about 20 years of smoking. With Maori people, because of the effect of cigarette smoke in our Maori population, you'll be looking at 15 years that you'll be starting to screen people. So the GP said in his referral he's quite regular with his meds, but is constantly short of breath on minimum exertion. Can I review him? So I did. So you can see that if we look at his spirometry, he's got COPD according to his spirometry, and yet he's not on any medication for COPD. Okay, so he's on medication, salbutamol nebulizers, Cuba. He's on medication which is used to treat asthma. And when we have a look at his eosinophils, a level of 0.0 to 0.2, which I've looked at over time, tells me that he's very unlikely to have asthma. So what would I be doing with this man? Well, we'd be looking at his fitness. We'd be taking a better history. He's Fijian Indian. I want to know if he's got any risk factors in his past that would have caused the possibility of adding to his smoking pack years. Sometimes we find that when people have smoked a small amount of cigarettes for a very long time, that they have COPD, which is quite severe compared to someone who might have smoked, 20 a day for 15 years, because he smoked it over such a long time in his lifetime. So we're definitely looking at his meds. We've wanted to know whether he's got, we'll be excluding asthma, we'll be changing his medications. I'll be getting pulmonary rehab, and his BMI is fine. Want to know how much exercise he normally does, and also what type of activity is causing exertion. So when I ended up seeing this guy, he actually walks quite far every day, but he gets short of breath when he goes upstairs. And when you dig into it a little bit better, it turns out he walks at a really, really slow pace for about 2 kilometres, like ultra slow. So he was quite unfit, actually. He had this distance he could walk, but it was super, super slow. And so he wasn't really doing much exercise at all. He was more like going out and checking out the neighbourhood rather than getting any exercise. And this person, 48-year-old Caucasian woman, very breathless with minor exertion, works as a cleaner. She's got a pectus excavatum. She's got gourd. She had asthma as a child, says she didn't have it as an adult. And when you look at her spirometry, it supports a diagnosis of COPD. And she's been treated with a serotype 250/50. I think she was the only person I'd seen in ages on one of those. And she also used quite a bit of Ventolin. So what have we got here? Well, the first thing I would be wondering about is whether that spirometry was, well, you have a look at that spirometry and you look at her history, and what we see is that she did have asthma as a child. And talking to her, she had quite severe asthma as a child. So some of that spirometry could actually be explained by damage done from poorly managed asthma as a child. The other thing is that she actually has a pectus excavatum. So the shape of her rib cage has changed, and that will also affect her spirometry. Now, she works as a cleaner, so she does have an occupational risk that could lead us down the pathway of thinking that she has got COPD. But she's also actually never ever smoked. And after some investigations, this lady has actually got asthma. She doesn't have COPD. And the reason I included this case study is just to illustrate that just because you can't just go by spirometry, that has to be looked at within the context of the person themselves. What we did, though, however, is we ended up treating her with a LAMA as well as an ICS and a LABA. And that is because she did have a degree of irreversible airways disease from damage done earlier. So I've been given time.
And there was somebody has asked if you see patients who smokes shisha sessions.
Oh, yeah. Had lots of conversations in my adolescent clinic about shisha. Tell them the same thing. God didn't make our lungs to process anything by air. And we lead on from that. In fact, I have a son who loves his shisha, and it's been a real uphill battle. He tells me he buys the non-tobacco one and the non-this one and the non-that one, but, I'm hoping he'll grow out of it soon.
Oh, thank you, Nicola. That's great.
Okay.
We have come to the end of our time for the questions, but people still keep asking me to send them the chart, and I can't do it unless you email me. So it's pauline@mobilehealth.co.nz. You email me and then you get it. And yeah, that's lovely. Thank you, Nicola. Thank you so much for doing such a good job.